Wonderful crowd to be here today. Join me again in thanking Paul for a wonderful presentation around. Thank you. Now, I have the unenviable task. By the way, I'm Jim Chase, I'm president with Minnesota Community Measurement, and very glad to be here today with this great group of people. I have this unenviable task of now, the quote is, connecting the dots from meteorology to healthcare's triple aim. Now, that's going to be hard, especially Paul's a hard act to follow with this. But when we put this together, we thought it'd be interesting to have Paul come and talk about the different context of using information and how that process has been improved over time. Would be a good kickoff for our discussion throughout the day here that we're going to have about where should we go with our measurement efforts in this community to continue to have an impact on the healthcare system and meet the coming challenges of healthcare reform. And not having heard Paul's presentation, I tried to imagine some of the similarities and differences between weather forecasting and healthcare quality measurement. The first one that came to mind is the weatherman does not control the weather, as he mentioned. And so if you're upset with the measurement results we do in healthcare, please don't blame us. I mean, it's only so much that we do, and it's really been this community-wide effort to do that. But more importantly, most of the time we're interested in the weather forecast so we can adapt to what it will be. You know, we wear a coat or we put on or bring an umbrella with us. But with quality measurement, what we've been doing in this community is we want to use the information to change the outcome. We're doing this measurement to see not how we are, but what we want to be. And I think that's the key of what we learned about today is to think about that future when he talked about redesigning his own organizations, that we need to do that constantly, both within our healthcare organizations, but also, we hope, within our measurement efforts that we have here in Minnesota. I wanted to share, Gail Amundsen, actually, who you'll see in a moment, sent me this article from the New England Journal of Medicine that cites the low rate of aspirin use in the United States for secondary prevention of cardiovascular disease, despite strong evidence of its efficacy. In the article, they actually bemoan the fact that the rates are quite low when not only is it a strong guideline that's been around for a while, but they even have a good hypothesis about the money that it would save if people use this. And in 2007, the national rate for prescribing antiplatelet medications for people with ischemic vascular disease was less than 47% around the country. In Minnesota, our optimal vascular measure is a statewide average for Minnesota, and prescribing aspirin has grown steadily since we began. It was about 80% when we began measuring this, is now up to over 95%. 95%. That's the difference between what's happening here and in other places in the country. And we see this higher level of achievement across many of our measures, from blood pressure control to optimal diabetes care to cancer screening. In fact, I pulled together a few just quick charts that you may be familiar with, but this is colorectal cancer screening and the changes that we've seen in that over time in this state. And while those are small percentages, it doesn't look like much when you think about it, that every percent increase, given how many people there are in the state that this affects, every percent increase is an additional 10,000 people who are being screened. And that's pretty amazing, and that's the work that everybody in this room has been doing, I feel, to move things forward. It's not just having the measurement infrastructure, but it's all the other things that have come with what we do here in Minnesota that has helped us to get these better results. So it's interesting, we'll be hearing in a moment here from Gary Shea from the National Quality Forum. But around the country, people, as I especially talk to folks in other parts of the country, they're amazed at what we have as far as the infrastructure here in Minnesota. But it's not just the measurement. I always like to talk about it's the collaboration that we have and all the components that comes with it. I'll tell a quick story. My son is 15, Joe, and he's a pretty good student. Last year, he had a little statistics segment in his math course. And they actually looked at some intelligence. One of their projects I knew was something about intelligence testing and what had happened with that. Well, a few weeks later in the paper, there was an article. It was interesting. I won't get this exactly right on the science of it, so bear with me. But it was about marijuana use in preteens. And the study had actually looked at early starters of marijuana use kids like 14. And what happened to there was actually, in the study, they showed an impact. It was small, but a few, I think it was 4 or 7 points in intelligence tests between those that started smoking early versus a control group for those that were older or those that had never smoked. And so I thought, well, this is a great teaching moment. I gave it to my son Joe and said, why don't you read this and tell me what you think? And knowing that he was, had this statistics course. And he looked at it, read it, and he came in and he said, well, I think what it means, if you're going to smoke pot, you should be an A student because you can afford to lose a few points. And I thought about that. He was actually, I think, right on the math of it, but especially if you know the bell curve and sort of that, a few points there wouldn't matter. But the conclusion was wrong. That wasn't what the study wanted to be. And so I always draw upon, it's so important for us in measurement to have the infrastructure that we have here around coming together to collaborate, to have ICSI in the community where we can identify what the guidelines are so people don't have to rely upon Joe and I to come up with what the interpretation is of various studies before we put them into measurement. I also wanted to share, though, I think another important ingredient has been this opportunity to work on things that we want to improve. And I used to put this in presentations, say, it's important, measurement is about improvement. But I wanted to say for today that it really, I think the difference for us has been we've had the courage to measure what we wanted to improve. And I'll give you an example that is a painful one, I think, for us this year. We had a lot of publicity for our C-section measure that just came out. And this, I think, was very important for us to do. The reason why our committees came up and decided to do this year was because we know that the rates have been increasing across the country since the 90s. There's serious concerns about what impact that has on the public. And so we felt it was important to, as we have before, to put information out about what's going on in the community, and so we put out a comparative measure. Now, quite frankly, the secret, as we know, is that it's not a great measure for comparison. It's not perfect by any means, because we haven't identified what's causing some of those differences across the practices that we reported on. But I do feel like it's an important measure because we've had the courage to put something out as a community around this is something that we should be paying attention to, and now we can come back and improve it over time to identify what can we find out about what's causing the variation in the community, because we know there are reasons why there are differences, but we can't point to what is causing the difference between various practitioners. And that's what's helped us to improve many of our measures in the past as well, that ability to put information out there and learn from each other about what works and what doesn't. Another key issue for us, I think, has been this culture of collaboration that we have and the opportunity to align across the community. We're very fortunate that here all the health plans have come together to use the measures that we have in a consistent way. So when we're doing them, we can reduce burden, but also increase the focus that we have in the community on the measures. But I also want to compliment, too, that we have the state government that's worked with us very closely over time to do this. And the state now has a statewide measurement system. And in some other states that are starting to go down that path, they've reinvented what's been going on in the private sector. And instead in Minnesota, we've worked together to try to identify the best ways to work together to move these measures forward and not be repetitive or reinvent the wheel on these things. And finally, I think just having this commitment to transparency has helped us to continue to use our measures and get impact for them across the community. I had to share, a big thing we did this past year related to collaboration was working with Consumer Reports. Many of you may be aware we did a 32-page insert in Minnesota edition and some of the surrounding communities with some of our measures. And I think what was important about this is Consumer Reports wasn't used to working with industry. They don't normally do that in their measures. They're worried that that would somehow bias the results. But it was a really good thing, I think, in healthcare where what we learned from each other, we learned some things from them about maybe it's okay to present the data in a little bit different way based on their experience about how people would use it. But what we really pushed for was making sure that we had information in there about how the consumers, how the patients could get better results themselves. This wasn't just about the performance of providers, but also about messaging about what you can do as a patient to do something differently. And they're quite good at writing that kind of information. We had the ideas. We were able to collaborate with our expertise in our community about what needs to be said. They were good about putting that in language that would work for people. And we hope this is a partnership that will continue as we go forward. This is just an example of our quality report. I did want to share with you just briefly that we have a number of new measures that we're working on this year, primarily just, again, to set some context for us as we get into the afternoon and talk about where should we head from here. But what's exciting is this will be the first year that we have a statewide comparable patient experience measure. Very important for the triple aim. Piece of that is patient experience, and we're going to be able to have that done in a consistent way and can be used, again, as we have with other measures. We're partnering with the state with working on the healthcare home measures. Many organizations are participating in the healthcare home system that's being administered by the state agencies, and we're working on measures with them that we've done collaboratively in the community around care coordination. We have a new pediatric preventive care measure, and very interestingly, one of the first places in the country that's working on a community-wide procedural specialty measure in the area of total knee and spine surgery measures. And we don't know where those will end up, or they're still in pilot stage, but I think it's a very important move, as we know, to look at not just the primary care measures that we can do, but also what about information in procedural specialties and how will that impact the care that people can receive. Also, we'll be working this year on a cost of care measures. We think also an important piece of the triple aim is to have cost information for the public. I don't know if any of you saw the Time magazine special of a few weeks ago. I found it very hard to read. It's an expose about pricing of services, especially in hospitals across the country. And it's not anything that I didn't know about, having worked in the healthcare industry for years, but to see it sort of in page after page and the scale of it now, about the differential between what people pay and the logic of it is very painful. So I think it's an area that we have to address, not just on the price as we know of individual procedures, which we've done some work on. We're about to renew that data or have renewed that data for this year, but more importantly, working for a community-wide total cost of care measure. And I think we have an opportunity there that's similar to what we've done with quality. Right now, all the health plans have different measures that they're using in their contracts for total cost of care. And it's an opportunity for us to come together and work on a consistent method of how we will report that and make sure that we have data available so provider organizations can verify it, but also have information that will help them to act upon the results to try to get better value for their patients. And I think that's a very important thing that will allow us to, as we have done with quality, not compete about how we measure things, but compete about how we use the information to get better results. Finally, I want to just share a few things about what's going on nationally, because we're going to hear in a minute from Gary Shea about the National Quality Forum. And as we've done so much to align efforts here in Minnesota, and we're ahead of many communities, I think now we have to be cognizant of there's a national effort to do measurement, and there's going to be a need to have measures aligned across communities. And so while we want to have an opportunity to be a leader, and we have in the sense of several of our measures have been endorsed by the National Quality Forum now and are being used in other parts of the country, we also need to be cognizant of what's coming out from other parts of the country and see where we can align that. And we've been participating in a group called the Measure Application Partnership that he may talk a little bit about. That's advising. It's a group that we have some representation on through Beth Averbeck, who is looking at advising what national measures should be for CMS for the Medicare and other programs that they're involved in. Another very important opportunity for us is in the Budget Reconciliation Act across the country that was passed in the beginning of this year. There's a change that allows CMS to actually deem registries to allow clinicians to then meet the Medicare requirements for certain programs through participating in local registries. What that potentially means for a place like Minnesota is rather than having to submit data multiple ways to multiple organizations, working through an organization like Community Measurement could mean then meeting standards for federal programs. And we do this now a little bit with the PQRS program you may be familiar with the incentive program that Medicare already has, but this opens the door to a much more robust effort that is a benefit both for us locally, but also I think for Medicare nationally, where they could get a much more robust participation and types of measures that we're doing in here in Minnesota to be applied broadly. We're working and supporting with other communities. We've just worked on a memorandum of understanding with Wisconsin. I know a few of you may be here from overlap that we have with providers between Minnesota and Wisconsin, but a great example of where we're pretty close. We've been doing measures slightly differently, and we need to work on aligning those and can do that with some other communities. And finally, we're now working, given that interest in developing some specialty measures, have realized we should be working with some of the specialty societies nationally that are that are developing measures in other communities or for wide use. But we have an opportunity both because we have a need for specialty measures here, but also could have some local champions who could work with us to make sure the measures are going to be the best that they can be, can have the biggest impact on patients, and actually demonstrate how they can be done. We've certainly experienced this, and I think it's interesting, touched on in Paul's presentation around, you have to try 10 different things to get one to work. I was just at a National Quality Forum meeting a couple weeks ago, and Patrick Conway, the Chief Medical Officer of CMS for all of Medicare, brought up this point, that we've been doing an odd thing in the measurement world. We've identified what we think is an important measurement, we come up with one, and we think that's the answer. And nowhere else do you think that kind of development is going to go on. And he was encouraging us to think about, we've got to try about 10 different things, the same thing we heard from Paul, to get one that's really going to be something that drives a lot of change and improvement. And I think from our measurement enterprise, we need to have that mindset, that we need to test things, we need to see how they work, and then redesign them if they're not exactly what we need. And finally, I just want to mention, and I put this what's next, why a question mark, because part of our work today we hope that we can engage you in is to think about what's next for us in the measurement environment, what should we be doing? And again, some of the things that we've heard about that we want to touch on to give you a little framework for this is, specialty care measures. Much of our work so far has been in primary care. What can we do with other specialties that will help drive value for the community and for our patients? What about gaps in the triple aim? So we're working on a few of those. We already have pretty robust quality measures. We're now looking at cost of care. We're about to have patient experience statewide. But a big piece of the triple aim is health, not just health care. My only caution with this is I think there's a great opportunity to do more health measures. But one of our impacts in the past has been not just doing measurement, but doing measurement that's attributable to somebody who can do something about it. And so we have to be careful as we move, I think, into the arena of measuring health, of identifying who's going to be responsible and what can they actually do to drive a change. But I do think it's an area that we can't ignore if we're looking at the triple aim and we're a healthcare measurement organization to look at health. Certainly there's a broad question for us around can we get beyond measuring specific diseases? There are 700 and some endorsed, I think we may hear more accurately, measures across the country, and that's just too many to be able to really manage our healthcare system. How can we get to some higher level measures? And it may be things like patient well-being that could be passed across a number of conditions and not just focused on each specific disease has a different metric that has to be tracked and calculated. And finally, I think there's still a great opportunity for us in consumer engagement. What is the information, not just for us around improvement on the clinical side, but would help patients understand what they can do, what information will engage them to get better results? So with that, I would just like to say we could take a few questions, but I know I'm between you and the break. Our next step is to take a break, and then we'll come back right about 5 to 10 and start with our presentation with Gary. But Jerry. Is anybody have any burning questions or comments they'd like to make before that? If not, we'll be on break and we'll see you back at 5 till.